Very good morning, and thank you, Rishad, for inviting me to this session. And so let's see why I think ICL should be the procedure of choice for a case like this with a 465 micron cornea. Now, when we talk about ideal refractive procedure, what are we really looking at? We are looking at that the uncorrected visual acuity should be equal to or better than preoperative best corrected visual acuity, should have a good efficacy as well as a safety index, should provide patient with a good quality of vision with a quick visual recovery, safe, minimal complications, and least chances of complications like regression and ectasia specifically. When you consider all of these factors, phakic IOL is the only procedure that comes to mind which fulfills all of these criteria. Now, let's look at a few results here. So if we look at results of ICL with central port, this is the V4C model which they had published data with 7-year data. So here the safety index remained at 1.05 at 7-year follow-up, and there was no significant increase in IOP or endothelial cell loss. There was no anterior subcapsular cataract at a 7-year follow-up period, which is reasonably fairly long. And we can see that there are no patients who lost more than one line of vision, and most of the patients had gained visual acuity. If we specifically look at ICL for low myopia, so this is one of the studies published again, and most of the studies quote that 85 to 96% of these eyes are within 0.5 diopters. And there is an improvement in visual acuity. There can be a gain even in low myopia. Definitely the quality of vision is good due to lack of high order aberrations that we might be inducing with a surface ablation. Another study which looked at very low myopes, here we can see that they implanted ICL in less than minus 3.5 diopters, and at a 1-year follow-up, both the efficacy and security index was maintained. So this tells us that ICL has very good results even when we are looking at low myopic patients. Now compare this with the studies that we have on PRK with a long-term follow-up in low myopia. So this is a 10-year follow-up of PRK, and here 42% of the eyes underwent retreatments due to regression, overcorrection, or both. So this is very, very significant. Most papers scored 25% approximately, but that might be due to lesser follow-up than this study. And when we talk about post-PRK ectasia, yes, although rare, post-PRK ectasia is not very common, but can still happen, especially when we are looking at a 465 micron cornea. We have to draw the line somewhere. We have to have some cutoff or a criteria for which corneal thickness we are going to do a PRK. So this is one of the case reports that was published in where they did a PRK for only 1.5 diopters and the patient had ectasia, although on reviewing the topography, they did find that there were some abnormalities and it was a form thrust keratoconus. So still there is a risk, especially when we have a thin cornea. And there is always an issue of post-PRK haze, although it is higher in high myopes, but it can be linked to fibrosis-associated genes, which can happen in low myopia as well. So these patients can also develop post-PRK haze. So to summarize, if we look at the quality of vision, it is better in ICL. The risk of ectasia, regression, haze, all of these issues are not there with ICL. The risk of dry eye is also minimal. And last but not the least, most importantly, ICL is a reversible procedure. So to conclude, therefore, ICL would be my choice. Thank you.
Thank you, Dr. IKEDA. So I'd like to just throw it open to the panel first. Professor Titial, sir, what would your take be, and would there be any role of things like biomechanics or epithelial mapping in taking this decision? Would that help? Or
I think first of all, I think we understand this patient wants refractive surgery, some sort of refractive surgery. I think that is the most important part for a surgeon to understand. The patient is adamant to undergo refractive surgery, then your choices will come up. And I understand it is the acceptance of a surgeon, he or herself, to do any procedure, because you have wide range of procedure which can be done for each amount of refractive error. And if I am convinced I am good in PRK, so you will be towards a PRK. If I am convinced I am good in ICL in terms of my results and long-term follow, I might go for a ICL. So first of all, it is the mindset of a surgeon to convince the patient. That will only happen if I accept this. So as far as I am concerned, -3 with 465, you have to have some your own guidelines, because there is no legal guidelines for many procedure in Indian scenario. So you can always be, challenged in the court. FDA guidelines may not be applicable in the legal area also. So my normally cutoff is, to 470 microns. And this is little plus minus 470 microns, despite having your, topography is normal. But age is also criteria, which Rajat mentioned, is not mentioned there. But if we do other assessments, do a biomechanics or do a, analysis of, other areas, as you talked about, epithelial mapping or a stromal mapping in these cases. And if I'm seeing this patient, maybe patient around between, 18 to 22 years of age, I might wait for another 6 months to 1 year for this patient. Assess. If things are all right, then might be, take the decision. But if patient is above 25 years, wants a surgery, stable these things, my choice might be towards the ICL for this patient, because I'm not for PRK for any patient. My percentage of PRK is less than 1% in last 25 years. So I might bend towards the ICL, especially is looking into the new generation ICLs and long results. My results in ICL is I started in 2006. So yet to have a serious complication in these cases, despite those generation ICLs also. And the results which IKEDA talked about is 7-year results. Results can say 7 years too less for a younger patient. But that is acceptable, I think. If look into my results for last, almost more than 25 years, it seems to be quite good.
Dr. Rohit, any role of extra procedures in this? What would you think in a case like this? What would be your takes?
I think both of them presented and defended very well. But what I would like to agree on with Dr. Rajat's case, one of our fellows presented a free paper yesterday. We are writing it up. We have assumed that corneal thickness of a certain kind is normal or abnormal. So we had this 3 years work on working on looking at the collagen imaging, and we did a PR case. It was with ethics committee approval and all that. So when you looked at the collagen imaging, what we realized is once where you have a normal biomechanics. When you say normal biomechanics, it's not the CBI, TBI, it's the SPA1 and SSI.
The stiffness parameter.
When you look at the stiffness parameters, and if the stiffness parameters are higher, like for example, your SPA1 is close to around 110, they correlated very well with the very healthy collagen. In fact, they were better than the collagen corneas of 540 corneas. So if you use a little more extra criteria into your assessment, and there are corneas which are thinner and your stiffness parameters are 70 or 80, so that means these are definitely a weaker collagen. So if you use that as your criteria, then I would agree with Rajat that PRK is also an option. But that is something, as Sir said, we don't have anything in the literature to help us with. Even if you're doing a procedures, I take a special consent form which explains that the cornea thickness is thinner, and I have been explained that this is an option, and explained that I have been given an option of ICL. So your regular consent forms may not hold good. So you take a consent form, whether it holds in court of law, we don't know, but at least you kept the patients informed. And PRK extra has really no value. We have realized that it does the same as doing just a good PRK.
And yeah, Dr. Rajat. Yes, ma'am.
So add a little, so there's nothing really much to add. Only thing that I would look at would be what the patient is aiming for. So is he getting it done for some occupational purpose, or is he into contact sports, or is a boxer? Because my decision would also depend on that for the choice of procedure that I would do. Rest, I think everything has been discussed. So
For boxer, you'll go for a...
For a PRK. If somebody doesn't want any sign of anything being done, then also I would go for PRK.
Correct.
That's a valid point, ma'am.
I had one, young lady, around 25, 26, housewife, put an ICL. I put an ICL in both eyes, and I think that night I had to fly for a AO, and she came in the evening with a fight with the husband, and husband slapped her. And I saw that this ICL1 happening outside the anterior chamber with the pupillary capture. just simple one, this thing. So it is, important factor there,
Yeah, Dr. Rajat, you wanted to say something.
I have a question and a comment. My comment is that the studies which IKEDA showed about regression and all, probably they are studies of 2007 and 8. And now with the use of mitomycin C, all those things have come down. And especially regression in -3 diopter corneas, it's probably very less. So my question to you is that when we were talking about biomechanics, if we do the biomechanics on two machines, one provided by Zeiss and one by the Oculus, are they comparable? Is the biomechanics as of now repeatable in those machines?
Not the Corvus and the ocular response analyzer
Yeah,
we are
sorry,
talking
sorry.
about.
Yes.
I mean, they two measures. They are not comparable because they measure differently.
Okay.
One measures the hysteresis, which is the viscoelastic
Yeah,
property.
OI.
The other one is the deformation of the cornea. So you cannot you cannot compare them. But if you use them individually, for example, your corneal resistance factor or the CH factors are lesser. But Oculus, the Corvus gives you a little more in-depth analysis of the corneal strength, like the SPA1 and the SSI indices. So they might help you to make a better decision. So when you say biomechanical normal, we only look at sometimes the CBI part of it, but that's a collection of multiple other parameters. But for a PRK, you should look at what is the deformation strength, and for that SPA1 and this would match. That matched very well with our the collagen imaging study, which we are trying to publish it, which will be the first case where we're showing that thin corneas are not unhealthy.
Okay. Thank you. Yes, sir.
Same patient. You said, as far as the FDA guidelines, you need to have a 250 microns plus residual wet thickness.
Yes, sir.
Suppose we go for a 80 or 90 micron flap. Why not you do LASIK for this patient where you are, all chances of haze will go off and quality of vision may be better.
So, sir, speaking strictly by literature, the PTA would be very, very high in that case then, because now we are adding 80 microns of flap thickness also. So PTA would go around 27, 28%.
That's less than 40%.
But still,
It's still in a manageable range.
so, but then the question comes to biomechanical strength. So I'm not very sure about what literature would say, but before presenting this debate, I would also not touch a 470 cornea for a PRK.
I think this
Now I
issue is, has to be, some sort of a guideline has to
Yes,
be.
sir.
We had to sit down, maybe, one of the associations and get, government's some sort of a tag in this refractive surgery.
So you are the best
So
person
we
to do
can
it.
make a guideline. What should be the, some sort of normative guideline for all refractive procedures.
So it will help all of us medically
Yeah.
also.
So maybe we'll start this.
The one you are having. The guidelines, the Indian Refractive Society and Cornea, which you are.
But no, we need to have some, stamping from the agencies, government agency in that.
Then it can be that if you have not followed that guideline, then you can be questioned in the court, and not everybody's experience is the same. So, for example, I would go for a PRK in a 465 microns, provided I find that that cornea doesn't look suspicious. So, but if the guideline says not less than 470, then I'm in a soup. So, we have to be very careful when we are laying down guidelines also, because
think they
then
have
it
to be-
becomes mandatory for other people to follow who have a different experience.
So at this point,
And not all thin corneas are weak corneas. You can simulate them to modern day women. They look fragile, but they are pretty strong. So please don't go by appearances. Appearances are deceptive.
but most important thing is taking a special consent is important.
Yeah.
Yeah, that we can mention, I think for to help the, larger group of people, sort of a lot of medical legal aspects are attached to refractive procedures. And those guidelines will be helpful for most people
Yes.
to, safeguard them, whenever you have a legal things.